Hello and welcome to the fifth episode of the Coronary Corner by SYSTOLE. It is my great pleasure to welcome again my partner, Yader Sandoval, who has been tremendous in spearheading this area. And today what we're going to talk about is about the barriers. This is based on the recent consensus document from SCCT and SKY about CT-guided PCI that Yader led. And this is going to specifically focus on the things that prevent us from being successful in implementing a CT-guided PCI program. So, Yader, I know you've put a lot of thought on this, talked to many people, both physicians and non-physicians, and you have a lot of insights about how to overcome some of the difficulties in implementing a CT-guided PCI program. So, how many categories are there? And let's go over them one by one.
Well, thank you, Manos. I think it's a very important topic to discuss barriers because, again, in full transparency about this field, I think there's a lot of, hype and hope and excitement about, there's this new application that we can use to help with our procedures. But yes, we all show this great PowerPoints and slides and people get excited. But now it comes real life. Can you execute all these things? And yes, there are some barriers. So there are 7 I would say common barriers at most sites that, depending on where you are, you will deal with one more than the other or several of them. So let's just go one by one and just chat about them. So I think the first barrier is patient eligibility, which can be patient or site-specific issues. What do we mean by this? What I mean by this is yes, we're thinking about CT can be great for pre-procedural planning, but let's think about first the patient prototype. So if you, for example, have a very high BMI, I'll tell you some example, like the pivotal trial right now for CT-guided, the exclusion criteria was 35 for BMI. So even some technologies out there will have in their, in their insert package that, if their BMI is above certain threshold, that that this technology may not be there. But in real practice, to your point, we see this all the time, right? But there's things like, patients' BMI, patients' heart rate, right? If they have a significant dysrhythmia, they're in AFib with RVR, that can really, now you may want to use CT, but it may be an issue. Other things that come to mind, renal function, right? It's a big one. It's a really, really big one. I know that this is, my wife's a nephrologist, so we'll have this discussion, this contrast-induced nephropathy or associated nephropathy. Is that a real condition or not? But I think it's still in clinical care. Your people are like, the EGFR is impaired. Maybe they don't want to do it. So again, little by little, I think you're putting together all these conditions that yes, I think this is a great emerging tool for us with our pre-procedural planning, but little by little, you start thinking about potential barriers, BMI, arrhythmias, renal function, and there's other stuff like even stents. I know you're using CT very proactively in patients that are coming for CT or PCI to your clinic to help with pre-procedural planning. What other barriers are you seeing, particularly from a patient or site perspective?
Yeah, absolutely. And the ones you mentioned are the big ones. Some people do have arrhythmias, but typically by the time for elective procedure, at least, they're well controlled. And the site, our team is very experienced to give metoprolol, other things to slow down the heart rate. Where we have issues is when you have an extreme amount of calcification, because even though they use specialized settings, high KV, still sometimes it's really hard to tell exactly what is going on. The stents is another big one, especially if you have multiple layers of stents because of the blooming artifact. But I must admit, I'm impressed at what they can do. We do have some state-of-the-art machines, not photon-counting, but still fairly good machines. And I think with the experience we have in our team, we're very fortunate they can scan pretty much everyone. I would say from all of this, the one that I'm the most sensitive to, even though there's debate about it, is about the kidney function. People who have a GFR less than 40 or 50, I'm very careful to prevent it, because then usually they come the day before, and if I'm going to do a big procedure the next day, I want to be cautious to not give them too much contrast that can then lead them into contrast nephropathy.
I think these are excellent observations. You alluded to something in your comments there that was this issue about better scanners, things like photon-counting. So as we shift from barrier number 1, which is this issue about patient eligibility, site and access barriers, then I guess the next one is hardware. And it is possible that maybe with better hardware, better scanners, we can potentially address and reduce some of these limitations in patient eligibility. You did introduce that with the concept of photon scanner, but just in general, I mean, you've been practicing, for several years, and probably all of us have seen a shift in technology. How has this impacted your practice, and what do you see coming forward?
Absolutely. I must admit, when I first started, when I moved here about 9 years ago, and I was looking at the images, I had still the guidance of expert people. It was much harder to see the fine detail, the occlusion length, the plaque composition, not quite as clear. With the current machines, it is amazing the amount of detail you can get. And I know it's been more slices, it's faster speed, so the machines have gotten better. But I must admit that the next frontier, which hopefully we'll get in our lab very soon, is the photon counting, where the noise is less and things like the blooming artifact from calcium, previous stents, become much less of an issue in getting clear images from the coronary CT. I'm sure this won't be the last one, and we should probably have a separate podcast just talking about the different machines with one of the imagers who has specific expertise on this. But my sense and my feeling is that it's going to keep improving, and the images we're going to be getting are going to be getting better and better. And that is why every interventionalist, as we discussed, needs to know about this. But this brings us to the next component, which might be more of an impediment to interventionalists, which is the software. Yes, you get the scan, and most places they can get the scan. Maybe it's not the best machine, but they can get a decent quality scan. But then how do you get access to the scan, and how do you look at the scan? That can be an issue. I know some people don't have access to software, or only the imagers have access. Some of them have access to online or AI-based tools. But what is your sense? What is the future going to be? Is it going to be new automated software that will make things democratized for everyone? Is it going to be getting access to the PACS analysis systems that is specific for every hospital? Where do you see the field going?
Yes. I think you hit the nail. Software for interventional cardiologists that are right now, again, if you're a cardiac imager radiologist, have been seeing this for a living every day, for as long as you've been in practice. But for interventional cardiologists that have not historically, I'm not talking about the structural cardiologists they're probably looking at this for TAVR, but the coronary, for coronary purposes, those that do not practice structural interventions, access to software has probably been arguably the main barrier. And I think we've alluded to this in some of the previous episodes. And I think this is right now something in motion. If we're talking about the basic software, many people say these are the post-processing tools to look at those raw data from the CT, from the DICOM. All hospitals that are performing CT will have access to a post-processing software, MIP, at the axials, at the MPRs, etc. So you can, I think it's an important point. Sometimes people are like, the CT-guided PCI is the future and I need access to this fancy software. It does help, but you can do a solid CT-guided PCI plan with standard post-processing software if you know where to click. Now, the number one barrier is that not with all softwares, but with many softwares, most of those out there, there's a number of licenses that they make available. So they say, you are X number of radiologists or imagers, and you are contracted to get X number of licenses. So therefore, the interventional cardiologists are usually not part of that special group. So that's an issue that I think it's a major barrier. And this is where I think, again, societal involvement, SCI and SSJT are leaders in imaging societies being aware that this is something that we need, and us collaborating and partnering with industry, and they're listening and hearing from us that this is an issue. I think it's incredibly important, because this will not move forward unless people can look at the actual images.
In an easy way, because some people may say, you can just go down to radiology or to go to your cardiac imager and look at the images together. But, it's not practically feasible for every case to come up from our third floor, whatever, go down to the other floor, find the imager. Is the imager available? It's disrupting them too. And obviously for complex cases, we do that and we'll continue to do that. But it will be important just yourself to be able, just 5 minutes before the case, log in, get the image up. I personally have been very impressed with the new online solutions. You click on a website, you put the patient's name, the reconstructions come, it's all segmented, it's very easy to look at it, the measurements are very straightforward, already been made. What is your sense about if this is potentially going to replace the standard full version workstations where you have to go and do the sophisticated analysis? Do you see this going to an online platform? You click on a button, everything comes up to you, and you can just get the elements that you care for CT-guided PCI?
I do think it's going to replace it, but it's going to really facilitate the interpretation of coronary disease, particularly for native vessels. It comes back to some things that we have discussed. So again, cardiovascular disease goes, as we all very know, well beyond just coronary disease. So many of these standard post-processing systems, our cardiac imagers are looking at this for structural interventions, aortic, mitral, left atrial appendage, vascular procedures, looking at the aorta. I mean, they're looking at the wealth of cardiovascular disease. So therefore, post-processing softwares are here to stay. They only get better day by day and more user-friendly, and they have to be in existence to support our imagers to, again, evaluate this wealth of imaging that sometimes, again, these post-processing systems are used by people in neurology, radiology. Again, it's the wealth of imaging. Now, for coronary diseases specifically, to your point, there are now a number of applications, particularly in this area that not long ago we were talking about the future of AI and machine learning and robotics and whatnot. This is no longer the future. This is the present. Particularly for us, interventional cardiologists, we don't intend to be, level 3, imagers. This will make it very easy, right? Because what takes you probably a lot more time with a standard post-processing system, with these AI solutions, some of these, computational things, you just go to a website, as you alluded, and it's going to give you, in 1 second, there it is, your best data set with the best reconstruction, with the best NPR. So you're pretty much now like not worrying about this. Just go ahead and click and interrogate.
And even your phone. I know you have it in your phone or you have it in your iPad, and then it's very easy to do. So it's here now, and I'm sure it's going to get better over time. So there's no excuse. People can start using it. If you don't have it in your practice, there are ways to get involved into this. But let's go to barrier number 4, which is about the evidence. And this is something that is also not there yet. I know P4 was just completed, and this is a very exciting study, 1,000+ patients. That's going to come out in about a year. But how do you see the current state of the evidence? And obviously, a lot of it is summarized into the consensus document. But is it enough? What do we need to go forward?
We clearly need way more data, right? If we, there's two ways to see this, glass half full, glass half empty. I think, of course, there's a lot of opportunities, but let's think about the standard, right? Right now, the standard for coronary imaging, things like IRIS or OCT, have class 1 recommendations are supported by large, multiple randomized clinical trials and meta-analysis. So I think the field as in general should aim to have a similar level, high-level data to support what we're doing. This is what we do. We really want to inform our practice by high-level, strong data, and this is where P4 and other trials do this. Now, to address your point, I think I've seen, I was actually part of a recent meeting where somebody also took it to the other extreme and said, we are in an infancy stage. I would not push it that much, right? I like to remind people that we have, and we've talked about this in a couple of episodes ago, we have already several trials, right? We have a randomized control trial for CT and CT or PCI, which we discussed a couple of episodes ago. We have not 1, but 2 trials showing that if we use CT in patients with coronary artery bypass graft surgery, it can also helps us reduce particularly contrast use and reduce the risk for contrast-associated nephropathy. We have a recent pilot trial for osteolesions. And of course, this is already in the base of a huge amount of data for CT-based physiology, for FFRCT, all these tools that we're seeing come out there for plaque. There's all these tools that are coming for total plaque volume and different applications. All of these ones are founded on well-established core lab analysis in comparison to IVUS and intravascular imaging. So again, don't get me wrong, we need a lot more data, particularly in the PCI, but I do think we have a fair amount of data, and that's the reason, again, comes back to us. I think that's the reason we've decided that we should bring this to our practice now, right? So of course, you've seen, all of us have seen that curve of, early adopters, innovators, skepticals and whatnot. We started using this more, but there was some data. How do you see this? what do we need? What evidence do we need to move forward and go from that early adopters to all users seeing the value?
Great point. Many studies can be done. For me, the low-hanging fruit, the one that we need to move the field forward, is a study in which you use a commercially available system to guide your PCI. Because most of the trials done so far, the big ones, they've done in a core lab. You send the films. It takes a few days. They come back. Someone processes them, give you. But this is great. But in real life, you're not going to have someone on the background to do all this work for you and spoon feed you all the information. So for me, for this to move forward, is to have a pragmatic trial or more, in which you use one of the currently available, commercially available systems. It does the analysis for you. You do it yourself, and then you implement it, and then you see how this compares than if you do it the standard way. And my feeling is that it's going to potentially help you save time, efficiency, safety, maybe number of stents, so many different things. Look at the practical implications, scheduling, how does it change the workflow and the outcomes of the patients implementing the system in day-to-day clinical practice. For me, this is the lowest hanging fruit, and I know there's things that in the planning, but this will really push the field forward.
Perfect. So the next barrier is, I think it's one that sometimes we also take for granted, but it's this issue of multidisciplinary collaboration. I remember, our good friend and colleague, Carlos Colette, as he was starting the P4 trial, he shares the story that when he was starting the trial, sometimes as they were doing the site initiation visit, this is where he was introducing the radiologists to the interventional cardiologists. And I think that alluded to the issue that we sometimes take for granted that not everybody, has a robust partnership out there, right? So to me, an exciting thing about this particular field is that it has led us to connect with our imagers in our community that we, again, outside of structural interventions, we have historically not really partnered with. But you tell me, Manos, I mean, you've worked in different places, interact with people around the globe as you travel to teach CTO on. How do we address this issue of multidisciplinary collaboration? What are the barriers and what is the value of it?
Yeah, great point. And I'm with you that most places, the imagers have no relationship with the interventionist. The only relationship is when you image someone and you send them for a procedure and that's it, and there's not much with it. And this is a lost opportunity for both sides. First of all, you can, as we discussed, make your procedure better if you really dive deeply. And as you know, we do have a very close relationship, and I will go routinely down for the complex cases, discuss with them. That helps us make our procedures better. But vice versa, I think they've seen a significant increase in the volume of cases they do. I mean, now pretty much every CTO, every complex PCI comes for a CT. So in a way, that helps that department, the imaging department, grow and have more cases and more complexity. So they get better because they see more and more complex cases than they used to see. So it's a mutually beneficial, apart from the interpersonal component where you meet people and you have a better care for the patient because you can discuss it in more detail. I think both departments can grow and do a better job when they work closely together. And I think we're seeing this more and more. I'm seeing many places these barriers are broken down, and CT-guided PCI, that revolution, that new wave, is playing a big role into that.
I think it's a great thing, and this is, again, going back to the SKY's CT initiative and the document. This is where I think we're going to increasingly see more imagers at the interventional meetings, and vice versa. The Imaging Society is going to have more proceduralists, their society, because we all just benefit from learning from each other. There's just different perspectives. One final closing on this particular barrier is that, again, the imagers are busy enough, right? They're doing a tremendous high volume of diagnostic work and looking at all these things that we've talked about, a structural procedure, vascular, congenital, and they don't want the interventional cardiologist also to come and say, like, hey, can you help me with this list of procedures for tomorrow? Because it's also not realistic. The key is to have the partnership, as we've had with our colleagues, that we have that partnership, that they've entrusted us with the tools, right? They're like, if you need to use virtual PCI, if you need to use some of these AI tools, if you need access to the platform, here it is, you drive with it. So that's the key of the partnership. You focus on diagnostic and high quality imaging, helping with the diagnosis and allocating and whatnot, but then we entrust your colleagues with the tools for that. Now, final element barrier, reimbursement. I know this is not the most...
If I can, actually that fits very well. Education. That's the number 6, education, and that fits perfectly because you're right, to be able to have a more meaningful conversation. I mean, beginning, 9 years ago, I was seeing them. They were showing me things. I'm like, okay, because I had no idea what I was seeing. I think the more you understand, the more meaningful conversation you can have, and it's better for both and for the patient. And this is an area I still think we have some way to go. There has been a lot of improvement. People can see the coronary CT images and they don't raise eyebrows anymore. But clearly there is room and need for more education. Many societies are taking up on that, but there's so many people to be trained. How do you think this can go forward?
This is crucial, right? I think, this momentum, which little by little is taking more strength, because again, it's not a surprise, right? If we plan our procedures beforehand, there's no surprises in the cath lab. It's just good for everybody. It's good for the patients, most importantly, and good for all of us. But I think at this point, little by little, we're crossing the bar that people have heard the message to some degree. People have seen the nice lights of all these elements that we've talked about. And now people are like, how do I do this? I've seen Dr. Brilakis, Dr. Sandoval, we've seen your slide a couple of times, heard your talk. This is all great. I have no idea where to click. So this issue of education is incredibly important. So this is where I think moving forward, what peers are asking is, teach me the how-to. And these are, of course, we've had the opportunity and privilege to partner with now teaching people. People are going to want, dedicated workshops, learn in a case-based format how to do these things, where to click, how do they actually do the CT-based MLDP and whatnot. So again, I think this is incredibly important. I would add that this is, again, like going to be like many things in life, right? Like radial adoption of IVDOS, adoption of modern physiology techniques. The young people have a great opportunity to change this. Why? Because younger, junior operators or fellows, many people, even including myself, we had the privilege that doing training, you get exposed to CT imaging. You want to do interventional, or this is your long-term plan, but you have a unique opportunity to do your general fellowship to acquire concepts that you can have the opportunity to actually integrate into interventional practice. But I think this is an incredibly important point that will require a lot of more efforts moving forward.
I can tell you from the older person perspective, we actually did not get trained in CT. At the time, it was very political between radiologists, so actually I never got formal training in CT. And it's much harder because it takes a while to get used to everything. But for me, having this hand-holding for a little while, okay, these are the buttons. You don't need all this, this software can be intimidating, especially the full version packs. This is like million options, is extremely intimidating. Understanding that you don't need to know all of that. You need to know 3, 4, 5 things consistently. See your NPR, see your MIP, the same thing discussed in the previous podcast. I think understanding that and learning from someone else how to click and getting started, that can go a long way and get the intimidation going versus starting from scratch to do the full analysis. This is very specific. It's not that crazy to do. With a little guidance, a day and a half of practical training, one can be up and running the following day.
I think it's a good point, and not to regress, but it ties to what you said. By us being independent and comfortable with looking at these components, we can actually integrate and facilitate the adoption and bring this to our cath labs, right? But my point being is that this will probably work in 9 out of 10 cases. But in the 10th case might be that 2 prior bypass, multiple CTOs and stents. There might be an occasional case that you say, like, this one, I'm going down. I want to find my imager because I want to partner with that. So this is, I think, where the partnership, going back to this multidisciplinary collaboration, works. And trust your interventional colleagues with the tools that your colleagues learn how to use this in most lesions. But like anything in life, there's going to be one that you're like, hey, this is pretty tough. Let me find my friendly imager and let's look at this together. So again, this is where there are synergies. Now closing thing. It's not the most exciting topic of the many things that we discussed, but it's a reality of an emerging field. An emerging field, I think, will not move forward at the local level, as a broad level, from research, implementation, adoption, getting better, without the barrier that we discuss in the SKYS as CT document, which is reimbursement. What is a barrier? How is it addressed? How do we move forward?
Great point. And of course, you have to have the test paid to be able to be done. To start with, many of those tests are done anyway. So for, I would say, probably a third of the cath lab people, or probably more than half now, that we see, they have a CT before. That's what actually led them to come to the cath lab in the first place. So for many people, you don't have to do anything special because the CT is already being done and you're just using the existing information to plan your procedure. And that's probably the easiest way to start because you don't need anything else. I can tell you for more complex cases, so for the CTOs I'm sending, complex cases, especially failed before, I have had only a few cases where insurance created issues for getting a coronary CT before. Maybe I'm lucky, I don't know, but I think for the more complex lesions where you need it probably more, you may get reimbursement without an issue. But for more wide adoption, I know there's a lot of advocacy from various societies, SCCT, SCAI, to be able to get the reimbursement, the insurance coverage to get it done. But as a starting point, if, let's say, you cannot get anything approved specifically for the planning of the procedure, taking advantage of what is already done is a good way to get started.
I agree 100%. Well, to add to that, this to me very, very similar to some of the various challenges that intravascular imaging have had, right? I mean, intravascular imaging, things like IVUS, OCT are cemented on a multitude of trials and meta-analysis, and we've talked about, but they haven't been implemented, and people have always discussed why is that? Is there lack of understanding of the images, lack of education? Is there a need for an incentive? Is there a quality metric that you need? Or is there a reimbursement that will incentivize this? So there's different models. I think that again, it's that will need to influence this, but I do think at a practical level, I guess I'll speak to some of our experience, my experience as well, is that this takes time, right? Again, don't get me wrong. I don't think it takes time to the point that it's affecting your day-to-day PCI planning. But as compared to the procedure that you don't do this, it takes, even when you're very comfortable, at least 15 minutes or so, I'm going to say, and do this, right? So if you're doing a pre-procedural plan, if you're embarking even, there's even data and science and people that are doing CT-based heart team approaches. So there could be argued that this is an emerging conversation, that there's additional efforts that are central on CT pre-procedural planning, that this is something that could potentially be recognized in order to support the effort in this growing field. So with that, Manos, maybe closing comments?
There are 7 barriers to implementing CT-guided PCI, and we cover them one by one. The first is the eligibility. With the new machines, new scanners, we're able to address and be able to get images in very good paces in most patients. The number 2 is the hardware, which is improving rapidly. Number 3 is getting access to the software, which is also getting there. Then we need some more evidence. Some more studies need to be done to be able to get the data needed to implement this more. Then we do have the need for education, more courses, more exposure of interventionalists to the field. Then collaboration is critical. Get to know your imager and work with him or her closely. And 7, getting reimbursement will help the field go forward. Thank you again so much for being for participating into the podcast. Thanks for watching us. And please, if you like this, subscribe to the podcast and look forward to seeing you in the next one.